A 34-year-old male patient with a history of uncontrolled diabetes came to emergency room with a history of sudden onset of sore throat. In the morning, he had very mild sore throat, and by evening, it became so severe, associated with odonophagia and dysphagia. And on examination, the patient was febrile with drooling of saliva, with a tender larynx. The larynx was tender, and the first diagnosis that should come to your mind should be acute epiglottitis. So today's class is on acute epiglottitis, which is very important clinically, and it can also be asked as short note for undergraduates and also for postgraduates. So acute epiglottitis. Okay, today's class is on acute epiglottitis. Acute epiglottitis. Important one. As I already told, it's a sure short note for UGs and PGs. Okay. So this one is a sagittal section through larynx. Larynx anatomy was explained in a previous video. And this one, this is sagittal section of larynx. This is soft palate, then tongue musculature, the leaf-like epiglottis, thyroid cartilage, cricoid cartilage. Okay, so this epiglottis is an leaf-like yellow elastic cartilage which get attached by a petiole into thyroid cartilage. Okay. Actually, this forms the anterior boundary of laryngeal inlet. This is laryngeal inlet. So this forms the anterior boundary of laryngeal inlet. Any inflammation of this epiglottis is called epiglottitis. So any short note should have a definition first. So first definition, that is acute epiglottitis is inflammation of epiglottis which occurs within a very short time. This happens in adults and children. In children, the commonest age group is 3 to 6 years, and in adult, it happens by 5th decade, that is in 40s, usually from 45 to 50 years. Okay. With a male preponderance, this becomes more severe in children. Why? Because the mucosa is loosely attached, so the infection can spread so easily, and acute respiratory obstruction can happen. Okay. So it's more severe in children. Then after definition comes the causes, that is etiology. What is the cause of acute epiglottitis? So this can be infective and non-infective. There are two main headings. Infective non-infective. In children, the commonest organism is Haemophilus influenza type B. H. influenza type B is a common cause in children, and because of vaccination with the HIV vaccines, in adult and in older children, the commonest cause is beta hemolytic streptococcus. Beta hemolytic streptococcus. It can be due to staph aureus also. There are so many organisms are there. I am telling only the commonest ones. Then strep pneumoniae, streptococcus pneumoniae can cause acute epiglottitis. Sometimes Klebsiella will also cause this. And in immunocompromised patients, this is caused by fungal organisms, mainly Candida and Aspergillus. Candida albicans and Aspergillus in immunocompromised patients. Also, these are the H. influenza type B, mainly in children, beta hemolytic streptococcus, staph aureus, then strep pneumoniae. All these are the infective causation for an acute epiglottitis. Okay. Then under non-infective causes, the first one is trauma due to a penetrating foreign body. Okay. So trauma, mainly by penetrating foreign body. Then it can be due to inhalational poisons, mainly chemical burns. So chemical burns can cause. Then systemic conditions like an uncontrolled long-standing diabetes mellitus. All these are the causes of acute epiglottitis. In any short note in a clinical scenario or clinical case, next is clinical features. So after cause comes clinical features. Clinical features should include symptoms and sign. So first symptom, especially in adult, there will be a very short history. So the first symptom will be a foreign body sensation. So in adult, in the morning the patient will have a foreign body sensation in the throat, and by evening it will get worse into severe dysphagia, odonophagia, and it can be dangerous, leading to sudden respiratory arrest. So in history we know that George Washington had acute epiglottitis. So in the morning he had mild sore throat, and by evening he had respiratory distress and died due to respiratory failure. Okay. So usually in the symptom will be having 3 Ds. Okay, 3 Ds. Drooling of saliva, then dysphagia, that is difficulty in swallowing, and distress, that is respiratory distress, drooling, dysphagia and distress. Okay. And in children this is more aggressive and progress very fast. Children will be more toxic, febrile, and with tachypnea. So in children, toxic child with tachypnea, and this child will take a characteristic position, that is sitting upright, leaning forward with a neck extension, so that can breathe more easily. Okay, and this one is tripod, we call it as tripod position. That is sitting upright, leaning forward with extended neck. Okay, so as to breathe more comfortably, tripod position. And on examination, on opening the mouth, sometimes there will be edema of tonsillar pillars. The tonsillar pillars will be edematous. Epiglottis will be red and swollen. That is characteristic. Red and swollen epiglottis. And in adult, along with epiglottis, aryepiglottic fold will be red and swollen, and the larynx will be tender. Okay, on palpating the laryngeal framework, it will be tender. Epiglottis will be red and swollen, along with aryepiglottic folds, edema of the aryepiglottic folds and false coat, with a tender larynx. On pressing there will be pain and also cervical lymphadenopathy. Okay, but we should not attempt a laryngeal examination once we are sure that it is acute epiglottitis. Never do a laryngeal examination, because if you do, especially the child will get agitated and can go for respiratory arrest. So a differentiating point from acute laryngotracheobronchitis is that in acute epiglottitis there will not be cough, and if at all the cough will be very mild. Okay, but in an LTB you will get a brassy cough. So cough will not be present, or the cough will be very mild cough. Okay, that is a differentiating feature with the laryngotracheobronchitis. In acute epiglottitis, the cough will be absent or will be very mild. Okay, absent or mild, but in laryngotracheobronchitis you will get a brassy cough. So remember these 3 Ds. Okay, drooling, dysphagia and distress, and on examination there will be redness and edema of the epiglottis with the tenderness of the larynx and cervical lymphadenopathy. Right? And if there is respiratory distress, this progressing to stridor, it will be an inspiratory stridor. Okay, inspiratory stridor along with a muffled voice, and this happens typically in children, this inspiratory stridor and muffled voice. Because in children, the difference from adult is that this progress very rapidly and airway compromise can happen very fast. So faster than in adult. And tachypnea not proportionate to pyrexia. That is important. Tachypnea out of proportion to pyrexia is a preceding sign of respiratory distress. You should be aware of that. Tachypnea, as a clinician, you should aware that tachypnea in not proportionate to pyrexia is a bad sign, and you have to anticipate it's an upcoming respiratory distress in that case, right? So after clinical features, next is investigations. Usually a typical history of very short duration along with a clinical feature will be pointing towards acute epiglottitis. So no need of further elaborate investigations. If at all you need, you have to take an X-ray soft tissue neck lateral view. So in investigation, the first thing will be an X-ray soft tissue neck lateral view. Okay, X-ray soft tissue neck lateral view. What will be the finding in this? In an X-ray, you get a picture like this. Okay, and in that case, you get this epiglottis will be swollen edematous. So it will be like a thumb. Okay, so swollen edematous epiglottis, you get a thumb sign. Thumb sign will be positive. It is very typical of an acute epiglottitis. And see, normal cases there will be a well-defined vallecula, because vallecula you see between lateral and medial glossoepiglottic folds. So a well-defined vallecula will be seen in normal case. But if the epiglottis is swollen and edematous, then this well-defined vallecula will be lost. So we call it as vallecula sign. Okay. So vallecula sign, thumb sign along with the vallecula sign, typical of an acute epiglottitis. Okay, loss of a well-defined vallecula along with the swollen edematous epiglottis. And definitely the total count will be elevated. And if you take a throat swab or a blood culture, in most of the cases it will be negative. Okay, throat swab or the blood culture will be negative in most of the cases. So don't waste time for that. Okay, if you need documentation or difficulty in confirmation of diagnosis, then only you can go with a throat swab or a blood culture. Otherwise, this thumb sign, X-rays of thumb sign and vallecula sign in X-ray soft tissue neck with an elevated total count will give a valuable information towards an acute epiglottitis. And another investigation which is of use is an ultrasound scan neck. Ultrasound scan of the neck. Through the thyroid membrane, you can see the P sign, alphabet P. Okay, and through the thyroid membrane in longitudinal view, you can see alphabet P sign. In longitudinal view, you can see P sign in an ultrasound neck. Okay, and if you suspect any complications, you can take a CT scan also. Okay, what are the complications? We will discuss later. Okay, so these are the investigations, and after investigation comes the differential diagnosis. These are the common differential diagnosis. First one is an acute angioedema. The presentation will be typical, and along with that there will be edema of the lips or the pinna or respiratory distress, and will be typical in history. Second is bacterial laryngotracheobronchitis. I have already told you that this laryngotracheobronchitis in children also present with an inspiratory stridor, but the typical brassy cough will be present in a bacterial LTB. Okay, cough will be present, but in acute epiglottitis, the cough will be absent, or if at all present, will be very mild cough. Okay, that is a differentiating feature with that. Next is peritonsillar abscess. Usually this typical examination finding edema of unilateral swelling of tonsils with the pushing of the uvula towards the opposite side. In foreign body aspiration and in thermal injury, typical history will be there. Along with the edema of the respiratory tract will be there. Mainly there will be a typical history of foreign body aspiration or thermal injury. Laryngitis, main differentiating feature is sound of the patient. In acute epiglottitis, because there is oral cavity and supraglottic structures are affected, there will be hot potato voice or a muffled voice. But in laryngitis, will be typically hoarse voice. That is important. Hoarse voice. Okay. And in retropharyngeal abscess, X-ray soft tissue neck will be typical. There will be widening of the retropharyngeal space. You can see the definite widening of retropharyngeal space in case of an RP abscess. Okay. So these are the differential diagnosis. Next, coming to treatment. Okay, how will you treat a case of acute epiglottitis? So in a suspected or a diagnosed case of epiglottitis, never send the patient back home and put the patient in observation or admit the patient. Okay, so observation for a minimum of 24 hours is a must in a case of acute epiglottitis. Okay, treatment. First, keep the patient in observation room or admit the patient. Observation or admission. Okay. And observation or admission, and observation for a minimum of 24 hours. Don't make the patient agitated. Allow the patient to take a comfortable position. Okay, that is very important. Don't make the patient agitated and allow to take a comfortable position. Next important thing is airway management. Airway management. Even in a mild form, you should be equipped with an instruments for either an endotracheal intubation or a tracheostomy. Okay. All the instruments should be available by bedside of the patient. Endotracheal intubation or tracheostomy. And this should be available at bedside. Okay. Tracheostomy, or in emergency cases you can even go for a cricothyrotomy. So instruments should be available. That is most important thing. Always you have to anticipate respiratory arrest or a respiratory distress. So instruments for endotracheal intubation or tracheostomy should be available. Okay. The next is IV antibiotics along with a 100% humidified oxygen. 100% humidified oxygen whenever possible should be given. And the drug of choice is second or third generation cephalosporins. Second or third generation cephalosporin. And the preferred one is ceftriaxone. Okay, ceftriaxone is the drug of choice. Can also give ampicillin sulbactam, or if the patient is allergic to this, chloramphenicol can also be given. So ceftriaxone, drug of choice, ampicillin sulbactam, or the patient is allergic, give chloramphenicol. Okay, this ceftriaxone, ampicillin sulbactam and chloramphenicol along with the 100% humidified oxygen. And the well equipped with an airway management, that is most important thing, because the commonest cause of death is a cardiorespiratory arrest due to respiratory failure. That should not happen in any case. Okay. Next is complications. All these are the complications of acute epiglottitis. Epiglottic abscess can happen. Then pulmonary edema. Then IJV thrombosis leading to Lemierre's syndrome. Okay. Then meningitis, vocal cord granuloma, because the patient is, especially in cases of endotracheal intubation, then pneumothorax, pneumomediastinum and pericarditis. All these are the complications. And all these should be remembered. The next is prophylaxis. That is, in order to prevent household or daycare contact to become carrier state, we have to give them prophylaxis. So, household or daycare contact to become carrier state, we give prophylaxis, that is rifampicin. Okay. Rifampicin is given as prophylaxis, that is 20 milligram per kilogram to a maximum dose of 600 milligram per day for 5 days. Some books tell it as 4 days also. So 20 milligram per kilogram to a maximum of 600 milligram per day for 5 days. Rifampicin as prophylaxis. Okay. So as a short note, these are the headings you must remember: definition, cause, clinical features, investigation, differential diagnosis, treatment, complication and prophylaxis to get a full marks. So next I will tell you the common pitfalls that can happen during treatment. This is not needed to write as short note. This is for the clinician, practicing clinicians to avoid clinical errors. Okay, that's a common pitfalls that can happen during treatment. There are mainly the 4 clinical pitfalls that can happen. Okay, the common clinical pitfalls. The first is underestimating the potential for sudden deterioration. As I already told, sudden deterioration to progressing to respiratory arrest can happen at any time. So never underestimate the potential. This is the most common clinical error that can happen. Okay. And second is inadequate monitoring, so that this sudden deterioration goes unnoticed. Okay. So I already told you, observation for minimum period of 24 hours with the close monitoring is needed, so that this deterioration will never go unnoticed. Okay. That you have to remember. The third is rushing to intubation. Don't try to become a hero. Okay, so never attempt an intubation without proper support. Ideally, an anesthetist with a adequate staff nurse should be there at the time of intubation, and all the instruments should be available at the near bedside also. So never rush for intubation without proper support. That is important, right? The intubation will not be easy as you think in case of acute epiglottitis. And the fourth is performing unnecessary procedures. Never perform unnecessary procedures like attempt to do an indirect laryngoscopy or a flexible nasopharyngeal laryngoscopy. Never do that. There is no need. At that time, the patient will get agitated and progress to a serious condition. So never perform unnecessary procedures. These are the clinical pitfalls in case of while you do treatment of an acute epiglottitis.